Welcome to the second of 4 webinars focused on advanced or cross-sectional imaging in veterinary medicine. All of these lectures are focused on MRI and CT related topics and provided by tremendous speakers who are experts in their field. This inaugural seminar series is sponsored by Hallmarq Veterinary Imaging. So thanks very much to them for helping us with this. Links to find out more about Hallmarq are provided on our Facebook site. Recorded versions of these lectures will be hosted on the Hallmarq YouTube channel and on our website, which is www.web-vetneurology.com. During the lecture, make sure to post your questions in the Q&A box, and we will attempt to address them at the end of this session. And today, we are privileged to have Dr. Elizabeth Goudie, who is going to address the challenging and all too frequently faced topic of anesthesia of the brachycephalic patient for the purpose of advanced imaging. By way of introduction, Dr. Goudie is a graduate of Ross University School of Veterinary Medicine. Following an internship, she completed a residency in comparative anesthesiology and a master's degree in veterinary medicine at the University of Minnesota. She then returned to the East Coast to found the anesthesiology service in a large multi-specialty practice, overseeing anesthesia in 4 hospitals for several years. Dr. Goudie founded Tri-State Veterinary Anesthesia in 2020 and provides anesthesia consulting in the New York City tri-state area. She is board certified by the American College of Veterinary Anesthesia and Analgesia, and is perfectly positioned, therefore, to talk to us about Frenchies and friends, and these cases that can really challenge us when under anesthesia. So, Dr. Goudie, welcome, and thanks for taking the time to talk to us about this topic.
Yeah, thank you very much. Thank you everyone for being here, in the middle of the day on hump day. So, but a nice little break. So we're going to talk about brachycephalics, and obviously there's several different breeds that fall into the brachycephalic category. Thinking more about Frenchies and English Bulldogs predominantly, and pugs, which I feel like are pretty frequently represented either with intracranial lesions or with like IVDD of some sort or some kind of disc lesion. So we'll talk about a little bit about the brachycephalic airway syndrome, as well as some of the other pathophysiologies that come along with a brachycephalic. We'll discuss their anesthetic risks. I'll do a quick review of a few pieces of literature that have kind of come out within the last several years. And then I'll talk a little bit about how I approach brachycephalic patients and what my approach is in particular. So each individual may have all or some of these changes classic to the brachycephalic. I find that all of them probably have these changes, but the degree to which they are affected is obviously variable. Similar to kind of horses that are regularly anesthetized over and over, that seem to learn how to be anesthetized. Brachycephalics that have had previous procedures and have done well, maybe outside, especially outside of their very early spays or neuters. And then I find that the older they are without any kind of airway collapse and airway crisis, the more likely they're to do well under anesthesia. Obviously, that's not hard and fast. There could be other things going on, other pathophysiologies that can worsen things, such as like silent pneumonia, which a lot of them tend to have. But it's the younger ones, the really excitable ones, the high body condition score ones that come in already anxious that we seem to have to be more worried about. So the classic brachycephalic airway is stenotic nares, hypoplastic trachea, elongated soft palate. Due to the negative pressure that's kind of created by this general stenosis of their upper respiratory system, we often see everted saccules or ventricles, bronchial collapse causing like a chronic bronchitis, and then laryngeal collapse as well. For the most part, I find that they can have really nasty stenotic nares and hypoplastic trachea and elongated soft palate, but maybe they haven't gotten all of these other things just yet. So especially when we have like a middle-aged patient, whether they've had BAOS surgery or not, I find that I always kind of want to make sure that these things aren't going on, and I expect them to be present. In addition, in Europe in particular, there's some groups that are trying to approach the hypertrophic turbinates and approaching those. In the United States, we're not doing too much with those. Obviously, you can do something about the stenotic nares and the elongated soft palate, do surgery for those. But if you're not doing anything about the turbinates, and you can't really tell that obviously just from external physical exam, those can be causing issues as well. And then one problem that I find that I feel like is underestimated often when we talk about brachycephalic airway syndrome is their macroglossia. And this is particularly present in the bulldogs, English and French. I don't find it as much in pugs or Boston Terriers, maybe Pekingese. I don't find it as much in those guys as I do in the bulldog group. And the macroglossia seems to cause some of my biggest problems. And I'm not sure if it's just further edema of a large tongue that occurs during general anesthesia, or they just can't move that tongue appropriately in the post-operative period or post-anesthesia period. But I find that I am always fighting with a large tongue. And I find that that is often a majority of my problem when trying to recover these patients, especially if they've already had airway surgery where their airway did not look that terrible when intubating them. Obviously, to go along with that is the gastrointestinal signs. And again, chicken or the egg, whether or not these patients have GI abnormalities already present because of their congenital abnormalities, obviously going along with their disc disease, going along with all of their other abnormalities that they have a genetic predisposition to, or is it the negative pressure that kind of causes a hiatal hernia and esophagitis and reflux to be occurring all the time? There's some evidence that they are hypercoagulable. There was a really nice review article that looked at all kinds of abnormalities within the brachycephalic groups, and they found that there was a tendency for hypercoagulability in these guys. So if they are procoagulable already, and then we have to do surgery on them, or we're anesthetizing them, which we know can worsen it, or they have another pro-inflammatory disease process, such as an intracranial lesion, or are they throwing clots into their brain? So it's kind of keeping that in the back of the mind. And then they can have systemic hypertension. So is that again, chicken or the egg? Do they have systemic hypertension that's causing their hypercoagulability and stimulating that Virchow's triad? So this is a nice image of a non-brachycephalic breed, dolicephalic patient, and then a brachycephalic. So you can obviously see it's a really nice image here. There's a difference in their cranium. There's a difference in the distance for air movement. There's all kinds of stenosis. You can see the difference here. Like where does this even connect to, if like compared to this? And then through the oral cavity, there's a nice blockade versus in the normal patient, and not to mention look at the sinuses that are absent here too. So anesthetic risk for the brachycephalic, so numerous comorbidities and should be classified as an AS3 always. Remember the ASA3s have one or more moderate to severe diseases. So airway disease, whatever they're coming in to see their neurologist for, and then likely they have GI disease as well. So to me, they've already surpassed an ASA3 for sure. And so I would call an ASA3 on like a young, otherwise healthy brachycephalic that maybe is coming in for disc disease. But maybe obviously I would bump them up into a 4 if they have like an intracranial lesion, when maybe on a normal respiratory, normal GI dog, I would probably maybe call that an ASA3. They often have elevated anxiety. And this is just generally for, I think, disc disease dogs or other neuro dogs. I find that a majority of my neurology patients, I find them to be clinically dehydrated. They maybe have not been eating and drinking properly for however long until the owner has brought them in. They're often panting and anxious. And so they usually are hemoconcentrated, and I find that most of them do need a nice fluid bolus. And this is just even more so for brachycephalics. They obviously have a difficult intubation, whether or not they've had airway surgery. That doesn't change their hypoplastic trachea. I often catch newer technicians, and I think this is something to keep in mind, newer technicians, interns, maybe just even techs that don't have a lot of experience with brachycephalics. Maybe they're not from the coast where we have so many of them. often grabbing something like a 7 ET tube for our French Bulldog. And I'm like, no, 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 no. Let's have a 5, 5.5, 6 ready for this patient. And we may even need to go smaller. The other thing that I like to have for my brachycephalic patients and really any upper airway disease patients are Cook airway exchangers. Mila also makes a Cook airway exchanger. It's a nice tool that acts as like a flexible blunted stylet, but also allows you to provide oxygen actively through it, which means that if you're having trouble intubating, you can throw this airway exchanger in and provide some oxygen. Obviously, it's not going to cause a seal, and then use it as kind of a stylet to pass your tube over it in order to get a patient intubated. These patients obviously are at a regurgitation risk, and at worst, that's aspiration pneumonia. At less worse is esophagitis. Bad esophagitis can obviously cause an esophageal stricture and cause just recurrent regurgitation, which then causes worsening esophagitis. And I find that the aspiration pneumonia often doesn't occur while they're intubated, but usually pre and post anesthesia. Obviously, we don't know exactly when, but the presumption is if you have a well-fitted tube with an inflated cuff, you're probably not getting aspiration during that time, but probably during that recovery period. So these guys should always kind of be kept as sternal as possible, not just to prevent your atelectasis and maximize what smallish airway space they have, but also to prevent them from aspirating. And then obstruction of the airway pre or post anesthesia, any kind of edema, irritation as you intubate these patients, often that is enough to cause increased edema. And a lot of times these guys will need a much smaller ET tube, a half size to one size smaller if you have to re-intubate them. I often will use some Dex SP. So I love an NSAID, especially in a back dog, but I will often wait to give my NSAID until I'm sure that my patient will extubate. While I've given an NSAID and a 0.1 or 0.15 mg per kg dose of Dex SP in an emergency, I prefer not to do it, especially with these guys and their GI signs. So I will hold off in case I need to give a steroid dose. These guys often have lower airway disease. We kind of talked about this already. Do they have silent pneumonia? Do they have chronic bronchitis? Just inflammation in their airway as well. And then you have a prolonged procedure where maybe they're on their back or on a side, and you get a patient that has a fair amount of atelectasis. Combine that with the upper airway obstruction and your lower airway disease, and you're kind of primed for a patient that can't oxygenate well in the post period. And a lot of them I find as they get older, in addition, have degenerative valve disease, which makes sedating them a little bit more difficult, and it makes differentiating like a respiratory situation and cough a little bit harder, and then often just makes the ASA status that much higher. So how do we minimize risk? So a few of the more recent articles that have come out, this one from 2025 from JAVMA, this is a really, I thought a really elegant study. It was really nicely done. I would have loved to have a few more patients, but they did a really nice job. It was a pretty big P. Or a pretty big N, I'm sorry, for this group. And it was coming out of Tufts, and so they implemented a standard perioperative protocol and for all of their brachycephalics. And so they were using pretty standard sedation, or including oral sedation for these guys. They were using prokinetic agents. They were providing nasal oxygen and nebulization. And so they, instead of it kind of being a anesthesiologist or a resident's choice and what they wanted to do, they just standardize what they do. And I would say that I do this in practice as well. I have a very standard anesthesia protocol that varies quite minorly depending on what kind of case I'm doing and what the patient's other comorbidities are, but I'm pretty consistent so that I know that I'm never missing something, and knock on wood, it's served me well. So I would recommend, and the other thing that they introduced was a pre-anesthetic brachycephalic consent form for the owners, and a checklist for the team prior to starting surgery or starting a procedure. So I would recommend, if you're looking for a really nice checklist, if you're looking for a nice brachycephalic consent form, both of those were included as addendums in this paper. So I would definitely recommend. I would say that the nebulization, it was an interesting point. It's something that we have started to institute in one of the specialty practices that I regularly consult in. One of the criticalists really likes the nebulization. We usually nebulize with epi. In this paper, I don't know that they were always using epi for their nebulization, but we use it and find a nice outcome. This one from 2019 from Vet Surge. It was a development of validation of a risk score, it's a brachycephalic risk score. I liked this one. I found that for anyone who's doing a lot of brachycephalics, it was kind of a little bit of a duh, no kidding. But it's nice to have something that is not subjective. That's an objective scoring system that you can then say to the owners, hey, there's this risk and that risk, and we did this scoring system. The score systems, some of them were interesting, whether or not there was a higher or lower risk after having brachycephalic surgery. There's obviously there were some limitations to this, where there was some of the patients had presented in respiratory distress, so obviously they were going to have a higher risk score as well. I just wanted to show you an image of that. So they scored these based on different point systems, right? So no prior airway surgery. So it was interesting that a history of prior airway surgery actually increased their risk. There was another smaller study that I believe came out of Ohio that actually showed a decreased risk after having airway surgery. So I think the jury is still out on this. And a lot of surgeons I work with and consult with, they're kind of mixed about whether doing airway surgery without a patient that's clinical is worthwhile. So if this hospital was doing something similar, where they were only doing airway surgery on patients that were already presenting in respiratory distress, then it would make sense that a history of prior airway surgery would be a higher risk, versus if they're just doing brachycephalic airway surgery on all patients that presented for, say, a spay or neuter and had presumptive airway surgery based on their breed. Additional procedures other than airway surgery, increased risks, make sense, more time under anesthesia, more manipulation of the airway, more chance for regurgitation and reflux, that kind of thing. Body condition score, obviously, the fatter they are, the less functional residual capacity they have, and you're already compromising an airway that's already compromised even further. And then this, obviously, if they needed intubation or oxygen sedation at admission, you can increase these points as well. But I think that this is kind of a nice thing to have, especially if you're teaching residents or interns or even new technicians, so that they can get an idea of, hey, putting a patient into oxygen and them needing sedation or them being noisy is out risky. This patient is more risky. And so so that everyone's a little bit more on high alert, because I think there is a tendency for maybe people to have had, good luck with these brachycephalics, maybe never had a train wreck. And so they're kind of shocked when it does finally happen. Sorry about that. And then Franklin et al. From Vet Surgery showed nebulization of epi reduced the severity of brachycephalic obstructive airway syndrome in dogs. This is a really easy thing to do. If you are transferring all your patients to ICU, which personally I do, just so I know that there's good eyes on them. I've had patients even in ICU where they have been doing fine. They've been doing great. They get up, they regurgitate, aspirate, and then arrest. So I really like to have eyes on them at all times, because I think they can do a lot of things silently and obstruct themselves without people noticing. Even if they've extubated well, they can take a few minutes, and 10, 15, 20 minutes, and suddenly get themselves worked up and obstruct their airway as well. So if they're already going down to ICU in the postoperative period, adding in this epi is a really easy, not that expensive of a thing to do, especially if you have a nebulizer already. This study was interesting. They used an interesting whole body plethysmograph and as well as a separate BOAS score from this previously validated one. I'm sorry, I don't have the year on here. I think it was 2020. That or 2022, they found that the whole body plethysmograph was much improved after they did this epi infusion or this epi nebulization in these patients, which makes sense. And I found that it shrinks down that kind of tongue, it shrinks down all of that inflamed tissue. And it makes sense if you've been involved in a upper airway surgery with these brachycephalics, most surgeons are now putting a mannitol soaked gauze at the back of the throat during the period that they're doing the alar folds after they've done the soft palate to allow for some of that edema to be sucked out. Because I think we all realize that any kind of inflammation and edema in that tissue is going to cause worsening. So consider scoring your patients and providing the brachycephalic consent form. Brachycephalic patients are found to be 1.57 times as likely to have intra-anesthesia complications, and then 4.33 times as likely to have post-anesthetic complications. So I think that this just goes to show why they should really be in ICU or have really dedicated staff watching them into the post-op period. They do have a tendency to obstruct and have regurgitation and aspiration. Providing adequate sedation. I provide all my brachycephalics that are planned oral trazodone, oral Cerenia, oral omeprazole. It was a bit of an older study, but a study looked at not brachycephalics, but regurgitation in patients in general. And that study found that omeprazole, 1 mg per kg, PO, SID for 3 days before anesthesia didn't necessarily decrease regurgitation, but it did change the pH. And so, yes, you're not decreasing decreasing the regurgitation, but you are increasing the pH. And the idea being that if you can decrease how much esophagitis and esophageal irritation you have, hopefully there's going to be less of a risk of esophagitis in the post-op period. And then maybe you won't get as much chemical pneumonitis in your lungs if you do happen to aspirate. And then I plus or minus gabapentin, depending on how young and wild they are, how much pain they're in, that kind of a thing. If it's an unplanned procedure, which obviously these guys have happen all the time, right? They have back issues and they need to come in. They have IDVDD. I will do oral or rectal trazodone. I find a lot of times these guys do not want me anywhere near their mouth. They're stressed out. They are angry. They are painful. I don't really want to be anywhere near their mouth, but most of them can't even feel really their anus. And they don't seem to care that much. And as most of us know, brachycephalics have a very clear shot right there. So I will take a red rubber. I base this on a JVAC paper that came out several years ago. They looked at 7 milligrams per kilogram of trazodone per rectum. I actually will do 5 mg per kg per rectum. I find that that's enough. Plus, I find the math a little bit easier. And I will crush that up with a pill crusher, mix it with tap water into, say, a 12 cc or 20 cc syringe. And I will pass a red rubber as far as I can up there into their anus, into their rectum. I will give them their trazodone and I will chase it with air. And of course, some is going to come out, but I do find that these dogs handle that a little bit better than trying to force something into their mouth. And the nice thing about the rectal trazodone is that it kicks in about 30 minutes as opposed to an hour. So if you want a patient to calm down and maybe you can't get a catheter in them, they're dyspneic, that kind of a thing, you can put the trazodone in, put them in an oxygen cage, and then come back and try again. Maybe you can't even get an intramuscular. Injectable morapatin citrate, obviously an antiemetic for these guys. I'll give them pantoprazole as well. And then I give them pre-medication to decrease their stress. I give them oxygen all the time. I am ready to provide it post-operatively. When I do any brachycephalic patients, I have called ICU and let them know that I would like them to turn the oxygen cage on. Most of the time, they do not need oxygen. Maybe they need flow by on a mask. Maybe they need a nasal prong for a couple hours or 30 minutes while they wake up. Fine, but I'd rather have it ready because every once in a while, they just want to be in an oxygen cage and not touched. And I find that sometimes the back dogs in particular are in that camp, and we just kind of have to watch them, maybe even with ice packs within the oxygen cage. And then always be ready to re-intubate. So I'll have the size tube that I intubated with, and then I'll have 2 or 3 sizes smaller than that. I'll have extra propofol ready. I have acepromazine. I have Dexmed ready in the post-op period. So aspiration. So what protocol should we be using for aspiration? So that paper, this Hill et al. Paper, they were using a lot of cisapride for these guys. And I have a friend who's an anesthesiologist down in Florida, and she and I were chatting actually about airway emergencies. We did a NAVIS talk, and we were talking about airway emergencies, and kind of course, brachycephalics and regurgitation came up, and she's using more cisapride. It's not something that I was really raised on. Unfortunately, cisapride was on back order for the majority of my training, and so I didn't have a lot of experience with it, but I know a lot of people really enjoy it. I usually use metoclopramide, and the reason is because of all the Deb Wilson papers out of Michigan. And all of her papers, she was kind of the regurgitation guru. And so her papers were always looking at metoclopramide. She had one paper in particular that looked at different doses of metoclopramide and then used a pressure sensor in the esophagus for a bunch of patients to try and figure out what dose was decreasing regurgitation. The limitations of that study, unfortunately, were that it wasn't a pH probe, it was just a pressure probe. But the dosage was 1 mg per kg of metoclopramide and then 1 mg per kg per hour to decrease regurgitation. I will say I have had patients get extrapyramidal. So normally I'll give them the mg per kg dose once I've kind of induced them, and then I will start the mg per kg per hour metoclopramide CRI and trying to stop that within 30 minutes of the end of anesthesia. And then I'll put them onto 1 or 2 mgs per kg per day. But we just really don't know what the best choice is. I always like to have chest radiographs beforehand. Do I always get them? No. And the reason is because a lot of times these guys have aspiration pneumonia already present or some kind of lower airway disease that I'd like to know about. And so that I know that things could be worse on the recovery. It doesn't necessarily mean I won't anesthetize them. If they can wait, obviously with pneumonia, I will have them wait. It also is a way for me to say, okay, if they come in, 3 days with aspiration pneumonia, I know that that was caused beforehand. And so we're kind of already ready for it. In addition, I'll add things like PEEP and do some more protective lung ventilation with them if they've already got lower airway disease going on. My protocol, so all my patients present with 5 to 7 mg per kg PO the night before and morning of trazodone, gabapentin 10 milligrams per kilogram PO the night before and morning of, Cerenia 2 mg per kg PO the night before or the morning of, just so that it's on within the 24 hours. I've been pushing for Cerenia more and more in my patients that are presenting where I have a plan ahead of time and not doing injectable. The reason is that subcutaneous Cerenia stings. It takes 30 minutes to kick in. And I find that, so I personally have terrible motion sickness, and I'm sure everyone is like this, but I really hate being touched or spoken to actually when I'm nauseous, especially from motion sickness, such as like on a plane or from in a bus or something like that. And so I often wonder if sometimes these patients are extra anxious or extra wound up because they are nauseous from being in the car and jostled around. And then we're immediately putting hands on them and touching them and stressing them out. So I like to have the Cerenia on board. And subjectively, I don't know if this is true, it would be a really nice study to look at, to do some sort of a like a sedation score and a anxiety score on these patients, whether they've had Cerenia or not beforehand. If no drugs are given pre, I will also give trazodone into them, either with a red rubber or oral. Again, unless they're like really excited about taking something orally, which I find most of these guys aren't because they're sitting there panting like maniacs, most of the time I can get a rectal trazodone into them and they don't even notice. My pre-medications, I usually use 0.01 mg per kg up to 0.015 mg per kg ispromazine intramuscularly. I find that at this dose, I'm not fighting a hypotension throughout the procedure. Depending on whether or not they have heart disease, depending on their anxiety level, depending on whether they're a naughty dog, depending on whether or not I always want to use ketamine afterwards, I will give them 3 mg per kg intramuscularly of dexmedetomidine, up to 5 micrograms per kg of dexmed. I find I usually only need 3 in these dogs, especially with methadone. My methadone is 0.3 to 0.4 milligrams per kilogram. I try and avoid hydromorphone in these guys more because of the panting, less because of the vomiting. I find that they just get hot and wound up as well. If you're just imaging these guys for something non-surgical and something non-painful, I'll just use butorphanol. For most of my brain MRIs, even if you're doing some kind of spinal evaluation and you don't think that this patient has a painful or surgical lesion, I'll use butorphanol. I think it's easier to reverse. I think it's a little bit smoother. There's a little less GI signs. There's a little less increase in vagal tone, which these guys obviously are predisposed to as well with their respiratory disease. I'll use butorphanol, and I really like butorphanol CRIs in MRI. My inductions are propofol and alfaxolone to effect. I like lidocaine, 2 milligrams per kilogram as a loading dose in my canine brachycephalics. I wouldn't use it in my feline brachycephalics. I'm not talking too much about felines. I find that, yes, they have some airway issues. And the biggest thing is that they can be a little bit tough to intubate. They might need oxygen post, but they don't have all the pathologies. They don't seem to have as many of the pathologies that the other brachycephalics do. I would still treat a cat and have them be come in on oral medication like gabapentin and Cerenia if you can. I would have them as low anxiety situation as possible, have extra oxygen, have them go into ICU in the post-op period. But again, for the most part, I don't find, knock on wood, my brachycephalic felines as big of a problem as my canines. My lidocaine, I really like the loading dose. One, it's a prokinetic. Two, it's a really potent and wonderful MAC sparer. Three, it decreases the cough reflex. And these guys already have a predisposition to have a very sensitive airway. And so I like the lidocaine as a bolus at induction. And then if they have wind-up pain, I'll add ketamine. I personally do not like to mix dexmedetomidine and ketamine. I know some people do. I know a lot of anesthesiologists do. My rationale is that I wouldn't give atropine or glycopyrrolate immediately following, like at the same or about the same time as dexmedetomidine. So why would I give a sympathomimetic? So that's why I don't use them together. But obviously dealer's choice, and there's plenty of people that do, so that I'm not saying you can't, but if I know that I want to use ketamine because this patient has like terrible wind-up pain, then I'll usually use ACE and methadone, and then a ketamine propofol induction with a lidocaine. Ideally, these patients should be maintained on PEEP, especially if you haven't gotten chest radiographs, or the chest radiographs look pretty bad. The PEEP really helps you with a protective lung ventilation, right? So to decreasing the amount of ARDS and respiratory trauma. If you have some positive and expiratory pressure going on these patients, then it takes a little bit less peak inspiratory pressure, and hopefully you can minimize your atelectasis by providing PEEP. Obviously within limits, right? You don't want to have your end-tidal CO2 too high, and you don't want to compromise maybe an unstable patient that doesn't have a good intravascular volume. But again, I'm often giving these guys a 5-10 ml per kg fluid bolus at the start before I move into MRI, because I find a lot of times they are fluid deplete from panting, not drinking, etc. If they can be on fluids before I have to anesthetize them for an MRI, that makes me very happy, but I know that often does not get to happen. They come in, they kind of run through the ER, they get seen, and they kind of have to get into the MRI immediately so that they can get surgery the same day. Maintenance with iso or sevoflurane and oxygen. And then often I'll do a CRI. And so when I talk about the CRIs and doing them in MRI, there's a couple of different ideas, right? So you can do things in different ways. You can do things like through the waveguard, but there's a lot of lines, and so you'll need extra boluses if the patient gets light, as there's no quick changes available. You can do it in an IV fluid bag, so there's a little bit of limitations on how quickly you can fluid bolus as well, but often we have 1 or 2 fluid pumps in there. You can mix it into 150, 50 mil, even a 250 mil saline bag, and have those boluses separately, or that CRI separate from your fluids that are going on. And then if I have an intracranial mass, I often am using total intravenous anesthesia. And I understand that 1 times MAC shouldn't really cause massive vasodilation, and therefore should not cause a significant increase in intracranial pressure, and therefore a decrease in your cerebral perfusion pressure. But when they have some sort of a lesion, especially a lesion that's been going on for a while, I always get worried that the normal homeostasis has been messed up. It's just kind of the same as when we have a patient with significant kidney disease at like an iris 2 or 3. We assume that they need at least a mean arterial pressure of 70, or a patient that's had chronic hypertension. We always try and keep their blood pressure higher than, say, like a normal patient of 60 or 70, because we're worried that that patient's set point has changed. And so I always worry that if they have some significant intracranial lesion, that even keeping it at 1 times MAC or even lower, that I will cause some kind of irregularity. So I'll grab a small bag, a 50, 150 ml bag, and I'll figure out how many mils I need of propofol, ketamine, midazolam, butorphanol, dealer's choice, and I'll run it in through a separate fluid line, in order to maintain them under anesthesia. And then for my IVDDs, and I know this is not necessarily having to do with MRI, is I have found a huge difference for any of you guys who are doing apaxial blocks. They actually got someone, a neurologist actually asked me if I knew about them, and I hadn't heard about it. And then I read the paper and I was sold. I've started doing this. And then if they're really crazy, I will give them an extra dose of trazodone rectally before they wake up. And these patients are just so comfortable. They're so much more relaxed. I was not using the ropivacaine that the paper had written about. I was actually using bupivacaine because it's what I had available, and finding really nice results. And it's a really easy thing for the surgeon to do as well. You can also give the metoclopramide bolus as the MRI is about to start, assuming that it's about a 45-minute scan or so. You can start the metoclopramide post, because it is a little bit tricky to add a metoclopramide CRI as well as any other CRIs going on. For postoperative care, if they're not or have IVDD, I give them more trazodone, 5 mg per kg rectally. I don't find that this slows down my recovery significantly, but I do find that it makes it so I don't need to give them ACE or Dexmed necessarily, and they just seem to have a much calmer recovery. It's just a little bit smoother than trying to re-inject them. I do have my Dexmed, a 0.5 to 1 mg per kg, and acepromazine ready to go. I often reach for acepromazine first. The only reason being is a lot of times I find these guys are hot when they're coming off the table, and the acepromazine will vasodilate them. It's longer acting, so I don't have to redose the dexmedetomidine. That being said, I'm always happy to give Dexmed, especially if it's a really nutty patient. It does have the analgesia that we have. You can reverse it, so I understand the other choices as well. I have extra propofol and then ET tubes ready for reintubation, obviously the laryngoscope, and then ICU knows I'm coming with oxygen ready to go. Before I move out of the OR, I always test my patient on room air to ensure that they can maintain their oxyhemoglobin saturation. So a lot of these patients will have lower airway disease. They have a lot of atelectasis from being anesthetized. Obviously, they've been denitrogenated. So I want to test them on room air. So I will recruit them. So I'll hold them at, like, say 15 centimeters of water for 10 seconds to try and pop open those alveoli. And then I will test them on room air. So I will keep them asleep and test them on room air. Remember that it takes a full 3 to 5 minutes for a patient to desaturate. So sit there while you have that going on. I also prop their mouths open and pull their tongue to the side. I do not have anything elegant that I keep their mouth open with, but I like it to be over to the side and to be soft, so I know that they can't hurt their teeth. So what I use is I wrap a 1 inch. I think it's a 1 inch, the standard 1 inch that you use for taping your IV catheters in, tape roll. I wrap it with a bunch of vet wrap. I then label it with brachy block, and usually there's some variable amount of hearts on it or something like that, when my techs get a hold of it. And then that way it kind of got a soft center in the middle that I can put between their canines, and I pull it over to the side and then have their tongue on the other side. And it makes it so that a lot of times these guys, they won't breathe through their nose, maybe from edema because of their airway disease, but they will breathe through their mouth, but they don't know to unless you kind of move everything out of the way. And I always tell people that once you've extubated them, if you don't hear any noise, and you might need to get near their faces, but if you don't hear any noise, that means they're obstructed. So a lot of times I'll have interns or students or new techs, and they're like, "Oh, this is going great," and I'm like, "This is not going great." And you don't realize that they're going to desaturate until 3 to 5 minutes. But if they're not making any noise, they're obstructed. So at that point, I open their mouth further, pull their tongue out more, put some flow by oxygen into their oral cavity. I'll even shove a oxygen breathing circuit right into their airway temporarily. And again, they'll have that brachy block kind of holding their mouths open. I often like to use a reflectance probe instead of a transmittance probe. So one of those flat probes, I will shave an area on their back foot and I will tape it on so that I can keep that pulse oximeter on them. And I have a heart rate. I can see whether or not they're desaturating, whether they're moving. And that's good for like if they're moving their mouths or they're trying to extubate. If there's a lot going on in their face, they don't want their faces being touched. I find that having that probe on there takes the guesswork out of there. And then especially if they failed extubation or if they have a really massive tongue, I nebulize with epi. If they have a really massive tongue and I've had to re-intubate them, I'm having a lot of trouble, or I'm really worried about that macroglossia, I will take 0.05 mils of epi and I will spray it just underneath the tongue. And I do find that the tongue will blanch and kind of shrink a little bit. I've tried to measure this with calipers and never had much success or luck in proving that their tongues have gotten smaller, but I have had luck with them, a patient that I've had to re-intubate, say twice, and I've done this, and then they've been able to extubate. And whether that was just time, the tincture of time, or what, I'm not 100% sure. Again, all my IVDD dogs I've ever anesthetized have always been clinically dehydrated. So I always start with a fluid bolus before I roll into MRI because they like to get hypotensive in there. If I can do a CRI in MRI, I find that my anesthesia is just really, really smooth. They're not trying to wake up. They're not hypotensive. I find that it actually makes the scan go much faster. So I'll mix a bag of lidocaine or butorphanol. And then if you're doing a lot of cases that day, you can actually use between the patients. I just change out the administration set. So even obviously lidocaine you can use for, painful procedures, butorphanol for non-painful procedures. I wouldn't use the lidocaine CRI on cats. And then you could do fentanyl. There's a lot of different options. You can use ketamine, etc. But I just find the lidocaine and butorphanol a little bit easier to use. So for 0.1 mg per kg per hour of butorphanol running at 2 mils per kg per hour, which again gives you plenty of wiggle room to use your regular fluids. In a 250 ml bag, I add 1.25 mils of 10 mg per mil butorphanol. And then if you want 30 mics per kg per minute, which is what I usually start with my lidocaine at 2 mils per kg per hour in a 250 ml bag, that's 11.25 mils of 20 mg per mil lidocaine. So with that, perfect timing. I will happily take any questions.
Thank you very much. That was great. Some great tips there. I really liked actually the specific checklist and the consent form. That's good info. So we'll be heading to that paper to try and get that. We do have some questions. You've answered quite a few of them actually, but the one question is, why not do this for all patients where this protocol, is there something specific in this protocol that you feel, well, that's not suitable for most patients?
I just don't think you need like the omeprazole, the pantoprazole, the metoclopramide in just standard patients. But I would say that it's not uncommon for me to be using ACE and methadone or Dexmed and methadone for a lot of my back patients. And I do CRIs for most of my MRI patients. So yes, there is some mixture. I think that this obviously includes the GI protectants, the extra concerns about respiratory compromise. So that's a good question. I mean, I don't think it varies tremendously, but these guys just have a little bit more risk.
Right. You'd mentioned about esophagitis, and you've talked about some drugs which may obviously help that with the talk about cisapride, metoclopramide, and omeprazole, lidocaine being a prokinetic. Are there other prokinetics that you would consider, or is that kind of the cocktail that you would be
That's usually
most
the
comfortable
cocktail. I will say, there's obviously erythromycin that critical care uses quite frequently, but again, that hasn't been looked at in the anesthesia setting. I feel like there's a lot of potential for another study that looks at pH changes within the esophagus for a variety of, breeds undergoing anesthesia using a variety of different prokinetic agents. It would actually be a really nice crossover study in like say a beagle colony to look at that. But we just don't have clinical evidence on it under anesthesia specifically. So I just don't use what hasn't kind of been written about.
Right. Question from Melody in Mexico. She says, do you use steroids in some cases to reduce laryngeal edema?
I do. I do. So again, that's what I was saying earlier. Like obviously, if they've already had an NSAID, I will still use a Dex-SP dose, a single Dex-SP dose, and just with the awareness that we need to watch them for GI signs. But if they haven't had an NSAID yet, maybe they're presenting to you for the first time for their IVDD, I will use a steroid in them. And then I think for the brain cases, obviously, if we have a high suspicion of an intracranial lesion, a lot of those guys are getting a steroid dose anyway. But yes, I'll use Dex-SP pretty regularly in my brachycephalics. I'm ready to go with that.
Great. What are there any red flags that would indicate proceeding straight away with a tracheostomy tube from the
Mm.
start versus intubation?
I don't know. And maybe I'm like just an eternal optimist. I do know some people are quicker, some surgeons are quicker to run to a trach tube if they've come in and they're not like in respiratory distress, which obviously we have to take care of their, if they're coming in respiratory distress and they're going to critical care or ER first, yes, and they need to get a trach put in already. If they're obviously already on the vent or something like that and they're getting an MRI to see what's in their brains because they came in maybe from a trauma like a TBI or something like that. I could understand those animals maybe having a trach, but I don't rush to it. I usually give them a few chances to extubate. I give them a few chances to be sedated, to just have flow by oxygen, etc. I'm obviously always primed and ready to reintubate them, but in my hands, I'm usually ready with the tubes. And so I'll put a tube in, and if I'm like, I really cannot get this patient extubated, so it's usually like a 3-time situation for me. If I've had to reintubate them 3 times, then I'm thinking about a trach, but I really hate to reach for them because I just don't think, I mean, a lot of these dogs can do okay with them. But a lot of them have a lot of extra skin. It's a big thing to take care of. It's a big expense. And once you've gone down that path, you're kind of there. So
Yeah, yeah, okay. Right, so I think one last question I have here is, um, uh, bearing in mind that a big focus in MRI is to keep movement of the patient to a minimum.
mhm.
Do you find more comfort then with inhalant versus the total intravenous anesthesia, or do you not really see much difference between the two?
I think if you dose appropriately, the Tiva actually is just as good as the inhaled anesthetics. And I have the same because I'm using propofol or alfaxolone to maintain my anesthesia. I still see some vasodilation. I still might need to mess with my dosing, obviously, just like when you're doing your imaging and you're not doing something uncomfortable. So you're not doing a craniotomy yet. You obviously don't need as much propofol or alfaxolone. You don't need as much inhalant to maintain them on MRI. I do find that adding the partial intravenous anesthesia, so just adding in that butorphanol or adding in that lidocaine, that ketamine, something like that in the MRI, I find that really minimizes how much up and down and movement I get during anesthesia with my MRIs.
Great, great. All right. Well, again, great talk. Thank you so much
No
for
problem.
giving us such a logical, practical, and very thorough review on this challenging topic. Certainly something that is difficult to find sort of good, up-to-date, experience-based information on. So seems that good preparation on some solid protocols are key in most of these cases. So yeah, thanks very much. That was
No problem.
fantastic.
Thank you
Um,
guys.
yeah. Oh, and thanks also to Hallmarq for sponsoring this webinar series. Join us for the next session on November the 13th, when Dr. Silke Hecht will be giving us an update on the imaging of round cell tumors in the nervous system. Until then, enjoy your Halloween, and we will see you soon.